Okay, now, so we'll go through the epidemiology of dyspnea now, okay? And it has been reported that dyspnea accounts for up to 7% of emergency room visits. Okay, and if we
Yeah, just a minute, we'll soon be back on. Some brief connection issues. Just hold on. We're also streaming live on Facebook on Cardiocare page. If you have friends that are able to use Zoom. Okay, so Dr. Awofisoye will come back on and continue the lecture now.
Okay, so I apologize for that breaking transmission. It was due to some network problems. So I was saying that about 50% of patients in cardiopulmonary clinics will have dyspnea as part of their predominant complaints. And if we review records of admitted inpatients as well, up to 50% of them will have dyspnea as part of the symptoms that they experience during their illness. And it has been reported that the likely etiology shortness of breath actually varies among age, more common among children, but by the time you get to older subjects, that's where you see things like COPD, heart failure, and other things like that, okay? So the likely etiology is quite variable depending on the age group that is being looked at. So if you're going through the pathophysiology of dyspnea, we know that the sensation or the experience of dyspnea actually takes place in the brain, okay? But the things that lead to this sensation depends on all these various metabolic processes that are listed here, including things like hypoxemia, metabolic acidosis, decreased compliance of the respiratory system, or increased airway resistance like we have in obstructive airway disease. And all of these things trigger changes in the various receptors in the bodies, including the carotid body, the chemoreceptors in the brain, the mechanoreceptors in the lung and in the respiratory muscles, and also the receptors in the airway. And all of these things is interpreted by the brain as an experience that is shortness of breath, okay? And it's important to understand this because this can show us that there's a wide array of events or changes in the body that can lead to the experience of dyspnea. So things, metabolic issues such as metabolic acidosis, things like anemia, heart condition, sepsis, all of these kind of things can contribute to dyspnea. And going further, there are some terms that if we describe can help us, at least will help the discussion better. So one of them is orthopnea, which we all know, dyspnea on lying flat, which is most often due to heart failure, even though, of course, some other can contribute to orthopnea as well. Paroxysmal nocturnal dyspnea is a unique experience, which is almost pathognomonic of heart failure. And usually, the patient has paroxysmal episodes in which he wakes up breathless, and that is usually transiently relieved by sitting or standing upright. Okay, other terminologies that we should consider includes hyperventilation. Hyperventilation refers to a state in which the primary problem is the person breathing too fast. Okay, and when a person breathes too fast, the partial pressure of carbon dioxide in the respiratory system and of course in the body declines, and then this leads to a relative metabolic alkalosis, and which can lead to some calcium some reduction in the amount of ionized calcium, which can lead to pleural paresthesias and tetany. Furthermore, we should talk about what cosmos breathing is. I'm sure we are familiar with this from diabetic ketoacidosis. And cosmos breathing is actually defined as deep labored breathing. And this is actually an attempt by the body to expel excess acid in order to compensate for the ongoing metabolic acidosis. So it induces some sort of respiratory alkalosis in an attempt to get rid of the excess acid. Okay. We also know platypnea, which is dyspnea in the sitting up position, and the term closely related to that is the tripopnea, in which this is often seen in unilateral pleural effusion and heart failure. Okay, so next we talk about the differential diagnosis of dyspnea. Whenever we encounter a patient that is dyspneic, various differential diagnoses has to run through our mind. And of course, we know that the most common or the most important causes of dyspnea are cardiac and pulmonary causes. Of course, it can be cardiac, it can be pulmonary, it can be mixed. Okay, but we also have many other causes of dyspnea outside the cardiopulmonary system. And this includes things like gastrointestinal GIT diseases, musculoskeletal diseases, neurological diseases, renal diseases, upper airway conditions, endocrine conditions, hematological, and even psychogenic conditions. So we just run through some of these so that we're able to tease them out when we experience seeing such patients. Of course, cardiac condition is one of the very dominant causes of dyspnea, and I'm sure we've all seen patients with heart failure and coronary artery disease. Some other cardiac conditions that is associated with shortness of breath includes things like arrhythmias, either tachy or bradyarrhythmias. Also, conditions like myocarditis and pericarditis is often associated with shortness of breath as well. Congenital heart disease is more often seen in children causing dyspnea, okay, but of course, many of these people can go into adults, and many of the congenital heart disease can actually be picked as the first time as an adult. Valvular dysfunction, most commonly mitral valve or aortic valve disease, are common causes of dyspnea. Cardiac tamponade is a condition that should not be missed, otherwise can lead to death fairly rapidly. And also cardiomyopathies are common cardiac causes of dyspnea as well. We have a wide range of pulmonary causes of dyspnea, and many of them are on this list. I won't go through them all, but most important of which is pneumonia, exacerbation of COPD, acute severe asthma, pneumothorax, pulmonary. We also have abdominal conditions. Some of these abdominal conditions can often present permanent dyspnea as well. But many times the patient can actually, dyspnea can actually be the dominant condition that the patient is complaining about. We know that conditions that increases the abdominal pressure, such as ascites, hiatal hernia, and even the common obesity, can reduce, can splint the. Other conditions will include gastroesophageal reflux disease, chronic aspiration, and shortness of breath, and also hepatopulmonary syndrome can also cause a patient to be dyspneic. Neurological causes, especially, just a moment. Neurological causes, especially conditions like the motor can lead to a sensation of shortness of breath by the affected, and other conditions like pain in parts of the body related to the chest wall or spinal cord injury can also lead to shortness of breath as well. We also have musculoskeletal causes, which are renal failure can be is one of the dominant causes of acute pulmonary edema. Okay, we have also other causes causes, including upper airway conditions, experience patients with this condition, okay, but the patient takes just a certain medication and then within moments it starts wheezing or has a stridor. So upper airway conditions can actually cause shortness of breath. Foreign body inhalation, smoking inhalation. Of course, foreign bodies that is compressing the upper airway can also cause this. It's also important to recognize the endocrine and metabolic causes of shortness of breath. Conditions like diabetes ketoacidosis, sometimes is a shortness of breath that will draw the doctor's attention to the fact that this person is actually quite acidotic. Thyrotoxicosis is also associated with dyspnea. Other toxicities including salicylates, carbon monoxide, some medications. And we should also remember that some extent of dyspnea is normal to experience in pregnancy. We should not forget that the metabolic basal metabolic rate is increased in pregnancy, and the minute ventilation is also increased in pregnancy. So the work of breathing is increased, and pregnant is not uncommon for pregnant patients to complain of feeling dizzy. Sickle cell disease with acute chest syndrome. It is also important to remember that there are psychogenic causes of dyspnea. Okay, and in general practice, I'm sure many of us have had that experience in which someone complains of either continuous shortness of breath or episodes of shortness of breath in the absence of any other obvious cause. Okay, so we should bear that in mind. Okay, but this should not be a primary diagnosis. Before we label someone as having a psychogenic cause or origin of fears or shortness of breath, one must have done due diligence in evaluating such a person, both with clinical evaluation and with relevant investigations as well. Okay, so how do we approach these patients? If a patient presents to our office with shortness of breath, most of the time, actually, the appraisal, the evaluation starts by just merely looking at the person that is entering your office and complaining of shortness of breath. I'm sure that we've seen the diverse ways that the people can present in that condition. So some people present with shortness of breath, and they're right there and there, you're seeing them, they're laboring, they're struggling to breathe, and you know that you have to help this person immediately. You see some people with shortness of breath, they are bloated up, they're edematous or have anasaka, and then you can already start analyzing your differential diagnosis in your head. Some you see they're fidgeting, they're obviously anxious, okay? Some will come and they have the fixie of Graves' disease, and you know that, okay, this person's shortness of breath may be related to thyrotoxicosis of the goiter. When we're evaluating such patients, we should first of all try to find out whether this is the acute or chronic condition, okay? Because the differential diagnosis of shortness of breath that began over minutes, hours, or days is quite different from that which began weeks or months ago, okay? Acute conditions, things like anaphylaxis, pulmonary embolism usually occur acutely, whereas things like COPD, heart failure, particularly from hypertensive heart disease, tend to be chronic conditions. We also want to find out from the patients whether these are intermittent or episodic events compared to shortness of breath that is persistent. So basically, we ask the person that, is this something that comes and goes? Are you perfectly well in between the episodes of the shortness of breath? Or is something that has been there largely all the time since it started, okay? So intermittent or episodic symptoms will suggest things like asthma, for example, ischemic heart disease can be episodic. Something like panic attacks can also be episodic. And in those episodic conditions, the patient is almost perfectly fine in between the episodes of the shortness of breath, okay? And this is compared to persistent conditions such as COPD, interstitial lung disease, etc. The other thing we need to find out is the situations or the circumstances surrounding the shortness of breath. Conditions that cause shortness of breath, irrespective of exertion, which I will term at rest, is quite different from that which causes shortness of breath only on exertion. Conditions like heart failure and many other pulmonary diseases can actually, at least at the initial stage, the shortness of breath is only on exertion, okay? By the time heart failure starts presenting with shortness of breath at rest, it shows a progression and an increase in severity of the condition. Okay, whereas the condition like asthma, for example, the shortness of breath is irrelevant of exertion. Okay, so the patient will feel the same symptoms whether he's trying to do something or whether he's just sitting still. The variation with position is also important. In patients with heart failure, for example, the shortness of breath will start initially on exertion, and later it will be quite prominent when they're lying flat. They'll feel better when they're sitting up. That suggests heart failure. I also mentioned earlier that some intra-abdominal conditions can also cause someone to be more short of breath when lying flat. With emotional stress, things like ischemic heart disease can be provoked by strong emotions. Even asthma exacerbations can be provoked by strong emotions. But we should not forget the psychogenic causes of shortness of breath. Most people who have psychogenic cause of dyspnea, like panic attacks and anxiety disorder, usually have more symptoms when they are emotionally triggered, so to say. Of course, experiencing shortness of breath only after certain exposures points to a reactive airway disease like asthma or hypersensitivity pneumonitis. So we should bear this kind of information in mind when we are evaluating a patient with shortness of breath. Okay, let's look at this case scenario together. This is a 67-year-old woman. Let's call her Ms. Smith. She presented to her GP with progressive shortness of breath on exertion, and she has been experiencing this over the last few months, but it's been worse in the last few days. And now she describes that she has to stop and rest after climbing a flight of stairs, and she can no longer walk more than 5 minutes on a flat ground without becoming quite exhausted. She now gives a background history of hypertension, and for which she has been on medication, and home systolic BP mainly between 140 and 150, perhaps a bit uncontrolled. And her BMI is also 32 kilograms per meter squared, so she falls on the obese side. She does not smoke. She has no productive cough or sputum production. So given this scenario, if we have this kind of patient in our office, what differentials will be going through our mind? And what other questions should we ask? So this is a woman that can be termed to be elderly. And we can see that the symptoms has been progressive, just worse recently. So this will qualify for more of a chronic form of dyspnea, okay, even though we should look for any acute exacerbation here. And the fact that it's worse on exertion, which has been more so lately, makes us think about a cardiopulmonary issue usually. Okay, so what other questions do we need to ask for from this patient? Okay, we'll get more clarity on how best to evaluate this kind of case as we're going on. Okay, so if a patient has acute dyspnea, even though the case we discussed just now is more of an acute on chronic condition, okay, but if we're seeing a patient with acute dyspnea, if the patient is in distress, we should go through a ABCD approach. And usually it's quite obvious if the patient complaining of dyspnea is in respiratory distress, okay? And we should always ask ourselves, just like the recent case highlighted, whether this is a new dyspnea or is it an exacerbation of a background problem. The ways in which the persons describe their symptoms can highlight the ways in which the person describe their symptoms can highlight the likely underlying condition. Okay, so patients with bronchoconstriction often describe it as a tightness, whereas patients with hyperinflation, like we see in COPD, often say that they cannot get the breaths to go really, really down. Okay, and of course we know that there's air trapping in COPD and hyperinflation. When we hear of orthopnea, as we've said a few times, you should remember heart failure primarily, but other abdominal conditions like obesity and ascites can also cause someone to be more dyspneic when they're lying flat. Gastroesophageal reflux disease can also cause a dyspnea that is exacerbated by lying flat, because of course we know that the reflux is worse when they're lying flat, and the irritation and inflammation of the respiratory system is worse in that position as well. Nocturnal dyspnea is quite typical of heart failure and asthma. And I've mentioned this earlier that if we have intermittent symptoms, you think of asthma, pulmonary embolism, and ischemic heart disease, in which it can be an angina equivalent. Okay, so talking about the onset of the dyspnea, of the difficulty in breathing, can actually be quite suggestive of the underlying etiology. Okay, and in this first column, where we put minutes, shows the common conditions that can start within minutes. Okay, so if someone tells you as a physician that I was quite normal yesterday, doctor, nothing was going on whatsoever yesterday, and the person is dyspneic today, we're not likely going to be talking about something like malignancy or anemia. No, usually it's something acute and something that started just sharply like that. Okay, and the kind of conditions there are things like pulmonary embolism, acute pulmonary edema, pneumothorax, foreign body inhalation, especially in children and in adults, aspiration, laryngeal edema, like we see in anaphylaxis and angioedema. Okay, so as we progress to hours and to days, we can see the conditions that are more likely to be presenting as the cause of the dyspnea. So things like asthma, heart failure, it takes more than a few minutes to come up, pneumonia, ARDS, and then by the time it's getting longer to weeks, you should consider things like anemia, pleural effusion, pericardial effusion, and even malignancies as part of the differential diagnosis. Okay, in evaluating a patient with dyspnea as well, the dominant symptom can actually suggest what the differential diagnosis likely is. Okay, so if the dominant symptom is something like cough or fever, we should think along the line of pneumonia. If things like asthma and COPD often present with cough primarily as well. If there's fluid retention and pedal edema, we should think of heart failure, renal failure. If there is a unilateral lower limb edema, we should think of something like pulmonary embolism. Also, if there's a wheeze, we should think commonly of asthma and COPD, which are probably the commonest causes of dyspnea and the wheeze. Of course, we should also consider things like anaphylaxis, heart failure, and acute bronchitis in a patient with a wheeze. If there's pleurisy, which is pain on deep inspiration, we should think of a pneumonia, pulmonary embolism, and pneumothorax. And retrosternal pain in a dyspneic patient is quite suggestive of acute myocardial infarction, pulmonary embolism, or pericarditis. And of course, many patients with dyspnea are also tachypneic. And if we get a history of hemoptysis, it means usually that there will be some extent of pulmonary parenchymal necrosis, which we see in pneumonia and pulmonary embolism with infarction. Of course, if the history is stretched a bit further, we should consider things like tuberculosis and malignancies in a patient with dyspnea and hemoptysis. And while we should try to let the dominant symptom and the duration of symptom guide us, don't forget that history is often unreliable, and many people can ignore or trivialize their initial symptoms, and they may only start counting the symptom from when it became quite serious. Again, I'll highlight the causes of acute dyspnea that are emergencies, and these are the things that are listed on this line: acute pulmonary edema, acute severe asthma, acute exacerbation of COPD, pulmonary embolism, and the rest. In these conditions, usually the person needs to be admitted in the emergency room, and we usually need to act very fast to avoid excess mortalities. Now, in considering chronic dyspnea, as listed in the earlier slides, the etiology is quite broad, okay? But the commonest conditions will likely be COPD, congestive heart failure, pulmonary embolism, which can happen chronically, okay? Pulmonary hypertension, lung cancer, and interstitial lung disease as well, okay? And usually, of course, in a patient with chronic dyspnea, usually we have the luxury of time to evaluate such patients in details, unlike a patient that is presenting acutely, in which we have to come to a diagnosis within a very short period of time. The features and examination that can guide us to the likely cause of dyspnea, again, that we should watch out for, includes wasting. If you have a patient with dyspnea and the patient is quite wasted, we should consider things like chronic obstructive pulmonary disease, tuberculosis, malignancies, HIV with opportunistic infections, including pneumocystitic gyratory pneumonia. If a patient is pale, we should remember that anemia on its own can cause dyspnea, okay? Because there's going to be a high cardiac output state, can lead to anemic heart failure. But even independent of that, because the oxygen carrying capacity of the blood is reduced in someone with severe anemia, they will get dyspneic doing things that should normally not get them breathless, okay? We should also remember that a patient that is pale can have malignancies, which may be obvious or not. And of course, patients with chronic kidney disease are often dyspneic, usually from a combination of pulmonary congestion from the fluid overload, and of course from the anemia and uremia as well. Many other chronic conditions that are associated with anemia can also be often associated with dyspnea as well. Dyspnea in a febrile patient is often suggestive of pneumonia, and the presence of paused lip breathing with a prolonged expiratory phase, which are obstructive features, should quickly point us toward obstructive airway disease. In the presence of edema, we should think of heart failure and renal failure primarily, but we should also remember that patients with chronic liver disease and portal hypertension, ascites can have dyspnea from portal pulmonary hypertension primarily, and also, like we described earlier, ascites often splints the diaphragm and prevents the full excursion of the diaphragm, leading to the sensation of breathlessness. Going further now, in the presence of bronchi, usually we should think of obstructive airway disease, but we should not forget that in patients presenting with acute pulmonary edema, they can often have bronchi as well, which has been labeled cardiac asthma in the past. Patients with upper airway obstruction can have stridor, which often can be picked even without the stethoscope, and is an inspiratory sound. We should remember that it's an inspiratory sound compared to bronchi, which is predominantly an expiratory sound. A patient presenting with dyspnea and severe hypertension, of course, we should often think of acute pulmonary edema in such patients. Okay, so going further, if a patient is the dyspnea patient that is hypotensive, should trigger all the alarms possible in our body, because hypotension plus dyspnea is often a sinister combination, and it's either most often it's either cardiogenic shock from myocardial infarction, cardiac tamponade, or pulmonary embolism. Okay, so if you have a combination of dyspnea and low blood pressure, we should act very fast. Again, a patient presenting with dyspnea that is found to have an irregular pulse, usually, of course, we should get an urgent ECG for such patients. Okay, but it's often a cardiac issue with tachyarrhythmias, atrial fibrillation. Of course, in that most of those will have some hemodynamic compromise, also cardiomyopathy. But we should also remember that pulmonary embolism often triggers cardiac arrhythmias, including atrial fibrillation. So anytime we have an irregular pulse, we should think cardiac, okay, but it can also be pulmonary, especially pulmonary embolism. It's critical to examine the JVP in a patient with dyspnea, and if the JVP is elevated, usually at least it streamlines the differential diagnosis towards heart failure, pericardial effusion with or without tamponade, and also fluid overload can also cause a raised JVP. Of course, listening to the heart sounds usually can guide the differential diagnosis as well. Gallop rhythm is common in heart failure. The heart sound is often muffled in pericardial effusion with or without tamponade. And of course, COPD, because of the hyperinflation of the lung, can make the heart sounds quite diminished. Of course, we should be wary of the obese patients in which the heart sound can simply be muffled because of the excess subcutaneous fat. If you're able to pick a murmur in a patient with dyspnea, it's often heart failure or valvular heart disease. Okay, the other important thing to pick on examination of a patient with dyspnea includes features of hyperinflation, which you can pick with hyperresonant percussion notes, okay, and with a barrel-shaped chest. So if you pick hyperinflation in a patient with dyspnea, particularly the elderly patients, it's often COPD. And some patients also can demonstrate reduced expansion of the chest, which can be obvious even on inspecting the chest or by performing chest excursion tests as well. We should look for tracheal deviation, which can be an important pointer of pleural effusion or pneumothorax. Dull percussion notes, particularly stony dull, can point us towards a pleural effusion, which should not be missed. Bilateral crackles is often found in heart failure, pulmonary edema, or pneumonia as well. And other things that we can pick up, particularly that can present with bilateral crackles, include interstitial lung disease, bronchiectasis. Okay. So when we're seeing a patient with dyspnea, especially a patient with chronic dyspnea, it's good to use a dyspnea scale to scale it. And this example here is the Medical Research Council dyspnea scale. If the dyspnea is of cardiac origin, it's probably better to use the NYHA heart failure scale, okay? So this is just very straightforward and actually can be self-administered by patients. So a patient that is breathless only with strenuous exercise, but still feel he or she is breathless is 1. If it's only when orin on a normal level or the person has to be walking a bit uphill to be breathless is 2. I think the rest are self-explanatory, okay, but we should, as much as possible, try to grade in a patient with chronic dyspnea. It's important to assess severity, and it's also important in assessing improvements with your treatment. So if you treat the patient over 1 or 2 months, for example, and the person goes from 4 to 2, you know that you made quite some progress. Okay, so I'll continue the case we were discussing before. Just go back to refreshers of the case. So here we are. Well, the 67-year-old woman that has this breathlessness on exertion. She's non-hypertensive. She's obese. She does not smoke. She does not have a productive cough or sputum production. So we discussed what other questions we should ask. And based on the things we've highlighted recently, apart from clarifying the history, we can use this examination findings to delineate our differential diagnosis. So here we can see that the patient has a mild ankle edema. The pulse rate was on the high side, even though not legally tachypneic. And the pulse was regular, was of full volume. She has a raised jugular venous pressure with a positive hepatojugular reflex. And the auscultation revealed reduced breath sound at the basis with fine crackles. There was also a 2/6 systolic murmur, that means it's fairly faint, audible over the mitral area. And the ECG was sinus rhythm, also showed left ventricular hypertrophy by the voltage criteria, and there were frequent PVCs. So I would imagine the diagnosis is obvious to most of us. Would have loved to ask questions actually, but I'm not sure how well the interruptions will work. But if you have differential diagnosis for this case, you can type it in the chat box. Let me just see what we think it could be. So what are the differential diagnoses that we think this patient could be having? So yeah, somebody has typed heart failure as a possible differential diagnosis, and I totally agree that that sounds like the most likely diagnosis. But are there other differentials? I'll tell you that even cardiologists have seen patients that they thought this patient was heart failure at first sight, but there are some things that we can still put at the back of our mind. Okay, but I agree that heart failure is the most likely differential diagnosis in this case. Okay, so we'll just go further to highlight some of the things that can present with dyspnea and how we should go on to evaluate a patient presenting with dyspnea. Okay, so after a good history and examination, most of the times you have a very good idea of the diagnosis. And in these situations, the next thing to do is just to do focal diagnostic tests based on the most likely diagnosis and treat the patient. Okay, but many times the diagnosis is not obvious or it's not immediately obvious. after the initial evaluation of the patient. And in such cases, the person, and in this case, I'm talking of a stable patient with dyspnea, by the way, the patient should get some first level tests, which often includes the chest X-ray, ECG, spirometry, complete blood counts, electrolyte urea and creatinine, and arterial blood gases, which sadly is often not available in our environment. Okay, so chest X-ray can help us clinch the diagnosis. More often, it just merely rules out many other differential diagnoses without really telling you what's going on. Okay, and ECG is very important in a patient presenting with dyspnea. Like we can see that many of the causes are predominantly cardiac and pulmonary. Okay, the spirometry is important, especially in the older person or in a patient with chronic progressive dyspnea, which usually will end up showing us a obstructive or restrictive pattern that can help us tease out the differential diagnosis. The full blood count is also important. Anemia can be picked, eosinophilia or other conditions, other blood cell changes that we see in allergic pulmonary diseases can be picked up. Okay, EUCR is also important in patients with hypercapnia. In patients with hypercapnia, they can have relatively high bicarbonate levels. Okay, so we should put that in mind. Of course, if this is done and the dyspnea is still unexplained, arterial blood gases is often useful to try to delineate the respiratory problems that the patient has. At that point, if the diagnosis is not yet clear, it is important to refer the person to a specialist for further evaluation. And second level test that is often done for such patients can include a chest CT scan, which can be a chest CT pulmonary angiography if pulmonary embolism is being considered. Echocardiography will be important at this time. Also, cardiac stress tests or cardiopulmonary exercise tests will be useful at this level. Other tests that can be done at this time will include D-dimer, which can tell us that there's a clotting problem going on or not. Of course, it has its limitations. Beta-natriuretic peptide and troponin is also a test that can be done at this level. We'll still go briefly through some of these tests later along the line. And basically, this is just some of this part of the pathway through which a patient with dyspnea can be evaluated. Okay, so I'll go further now. Many times we try to distinguish whether a patient's dyspnea is primarily from the cardiovascular system or from the respiratory system, and it can be quite difficult. Okay, but a cardiopulmonary exercise test can be useful in identifying which one is the most prominent, system contributing to the patient's dyspnea. Okay, and in patients in which is primarily a respiratory problem, oftentimes when they achieve at the peak of their exercise, they develop hypoxia and bronchospasm, compared to a patient with cardiac cause of the dyspnea, which many times they will have changes in their blood pressure and heart rates even before they get to the maximum exercise level. Okay, so I'll just go through some of the causes of dyspnea now before we hone down on COVID-19 and how to approach it in this time and in our clients. So pneumonia is one of the very common causes of shortness of breath, particularly presenting acutely. And usually the patient will have had a recent upper respiratory tract symptoms, either sore throat, catarrh, and of course, usually at the time of presentation, the presence of fever and cough with the dyspnea suggests that it can be a pneumonia process that is going on. They may or may not have chest lines. Okay, and the evaluation, the investigations that should be done for such a person depends. If it's very straightforward, sometimes no investigation is necessary. But many times the patient gets a complete blood count, which can show this leukocytosis, often if it's bacterial. Also, the inflammatory markers like ESR and CRP can be elevated as well. When indicated, which is not often, but when indicated, microbiological tests can be done as well, which can include a sputum analysis and culture, and also urine tests for strep pneumonia when available. Of course, a chest X-ray is not routinely indicated in pneumonia, but if it's severe up to a certain extent, okay, or it has not responded to first-line treatment, of course, a patient with chest signs, a patient that requires inpatient care, will require a chest X-ray. Pulmonary embolism is also another common cause of dyspnea. Sadly, it's often missed, okay, but the things that should point us towards the possible diagnosis of pulmonary embolism will be presence of risk factors, okay? In a patient who is common with shortness of breath, with or without cough, if they have risk factors for pulmonary embolism, we should have a very high index of suspecting it, okay? And such risk factors can include things like a previous history of pulmonary embolism, a sedentary lifestyle, or recent immobilization, recent travel with a travel duration greater than 4 hours, a known malignancy, a recent surgery, a pregnancy, okay? Those are all things that can point us to a higher risk of pulmonary embolism. Also, if the dyspnea is associated with chest pain, cough, hemoptysis, dizziness, we should suspect pulmonary embolism, okay? And on examination, many times signs could be sparse actually, okay, but the patient is often has tachycardia, and the blood pressure can be normal, low, or elevated. In such patients, we should look out for a DVT, which is quite common in them, and the investigations that should be done depending on how likely the diagnosis is, and that means before we do investigations for a patient presenting with suspected pulmonary embolism, we should do the preclinical scoring to determine whether or not there's a high or low likelihood of pulmonary embolism. This is usually done with the Wells score or the Geneva score. Okay, so the investigations that should be done will now include things like D-dimer, if it's a low probability, there's a low probability for pulmonary embolism, chest CTPA, that's CT pulmonary angiography, and ECG and echo is important as well. And in our environment, it's often more available than the CTPA. Also, VQ scan can be done in certain circumstances. Other investigations that should be done include a pregnancy test in females and a thrombophilia panel when necessary. This can include things like cardiolipin antibodies, protein C, protein S, antithrombin 3, and others like that. But that should only be when necessary. Okay, so some of the other causes of pulmonary of dyspnea includes acute pulmonary edema, which is very common, like we all know. Acute pulmonary edema is often cardiogenic, but can also be non-cardiogenic. In patients presenting with acute pulmonary edema, it's often due to, the cardiogenic ones are often due to left ventricular failure, which can be from hypertensive heart disease, acute coronary syndrome, okay? And usually it's a clinical diagnosis, and we suspect it when the patients come with shortness of breath. Often they have cold extremities, they are sweating profusely, they are pale from peripheral vasoconstriction, and they are restless. Many times, if they can have evidence of fluid retention, and they may not, okay? And the patient is often invariably tachycardic with elevation of JVP. Usually they are unable to lie down flat, and they are quite restless. And on examination, the bilateral basal fine crepitations often gives away the diagnosis in the context of all these other things that I highlighted. Like I said earlier, it's a clinical diagnosis, and we should not wait for any of these investigations actually before we make a diagnosis of acute pulmonary edema and we start treating it. Of course, there are classical chest X-ray changes, which often involves cardiomegaly if the cardiac cause has been ongoing for a while, so there can be cardiomegaly, but more often what's more consistent is pulmonary vascular congestion and upper lobe diversion of the blood vessels. Also, of course, you can see opacities, diffuse opacities, usually at the basis of the lung, and then later on can form a bat wing appearance in the perihilar region. Of course, you can also see changes like Kelly B line and interstitial edema. Sometimes, of course, X-ray changes can also involve the pleural effusion, especially on the right side, but can be bilateral. Okay, of course, other investigations are important in a patient with acute pulmonary edema, but as I said earlier, it's important to start treatments even before we get all these other investigations, okay? And the investigations that are important include things like the ECG, the echocardiography, of course, troponin, the BNP, and EUCR are important. Don't forget that acute pulmonary edema is not a complete diagnosis, it's secondary to something, okay? If you say it's cardiogenic, it means it's secondary to a cardiac problem, and that cardiac problem needs to be identified and treated even while we are treating the acute pulmonary edema. Okay, so we also have non-cardiogenic pulmonary edema as well. And non-cardiogenic pulmonary edema is pulmonary edema that is not due to heart-related hydrostatic changes. Okay, so the mechanism in pulmonary edema, in the cardiogenic pulmonary edema, is due to the increased hydrostatic pressure in the pulmonary vasculature, which is secondary to a left heart issue. Okay, but now in the non-cardiogenic one that we're talking about, it's not due to hydrostatic changes primarily. Rather, it's due to increased permeability of the pulmonary capillaries. Okay, and once those capillaries have an increased permeability, that's increased leakiness, there's more aggression of fluid into the pulmonary interstitial spaces, and of course the lungs literally becomes wet and cannot carry out its basic function of oxygenation. To define that there is increased hydrostatic changes from the heart is not the cause of this pulmonary edema, it's important that we demonstrate that the pulmonary wedge capillary pressure is normal, usually below 18 millimeters of mercury. Of course, measuring this is often not available in our environment, and we have to depend on clinical parameters in that there's no cardiac disease that explain this extent of pulmonary edema or hypoxia in this person. There's no clinical evidence of fluid overload. There's no clinical neck vein distension, and that's why we have to carefully look at the neck vein in the 45-degree position. Patient should turn to the other side as necessary, should tilt the neck to the other side as necessary, and we look carefully for neck vein distension, and we also assess the hepatojugular reflux. Okay, we should also assess for pedal edema in such a person, and once these parameters are absent, it makes it less likely for the pulmonary edema to be cardiogenic in origin. Also, a chest X-ray can give some guidance. The cardiomegaly and the pulmonary venous congestion, the upper lobe diversion that we typically see in cardiogenic pulmonary edema is absent in non-cardiogenic pulmonary edema. Of course, an echocardiography is important in fully clarifying the diagnosis. And once we can demonstrate that there is no acute systolic or diastolic dysfunction on echocardiography, it tells you that the pulmonary edema that we are seeing here is not cardiogenic in nature. Okay, so one of the most well described type of non-cardiogenic pulmonary edema is the ARDS, which is the acute respiratory distress syndrome. Okay, and is an entity characterized by severe hypoxia and bilateral lung infiltrates on imaging in the absence of a cardiogenic cause. Okay, the hypoxia is severe, and I think that's one of the defining things of ARDS, apart from the bilateral infiltrates that is there. And of course, there is a wide range of causes which we cannot go into in this presentation. Okay, but we should know that generally speaking, the cause of ARDS can be broadly divided into direct causes and indirect causes. The direct causes are the things that affect the lungs directly, things like pneumonia, aspiration, near drowning, or inhalational injury, which can be inhalation of smoke or toxic substances. Whereas we also have the indirect causes, which the commonest of which is severe sepsis, but we also have other conditions, including major trauma, Trale is transfusion-associated lung injury, and also pancreatitis. And in making a diagnosis of ARDS, of course, chest X-ray is important because we have to demonstrate those bilateral pulmonary infiltrates. Arterial blood gases is also important, even though an SpO2, that's a pulse oximeter might suffer, it can demonstrate that this person is desaturating despite a reasonable amount of oxygen. Usually, someone is desaturating at oxygen levels above 4 liters per minute. In the absence of a cardiogenic cause, it's usually ARDS. Also, ECG and echo is important to use to exclude a cardiac cause. In a metabolic panel is important. And often patients with ARDS requires ICU care with central venous pressure monitoring. And it has a high mortality in the range of 40 to 70%. Okay, I think that's it there. Another important cause of dyspnea in our patients is pericardial effusion. I'm sure we've all seen patients with pericardial effusion before. It's important to note that what determines that a person is in tamponade is not the amount of fluid in the pericardial space. Rather, it's actually the rate of accumulation, okay, and the consequence on cardiac filling, okay? So someone can go into cardiac tamponade with as little as 500 mils in the pericardial space, and another person can have 1,000 mils without being in tamponade at all, okay? If the fluid accumulates slowly, it gives time for the pericardium to stretch, and more importantly, for the heart and even the rest of the body to adapt to it. And this is contrary to when the accumulation of fluid happens rapidly. For example, either from radiation of the pericardial region or from trauma. So if the fluid accumulates rapidly, the heart does not have a chance to make necessary adaptation, and of course, the consequence can be devastating. So pericardial effusion usually presents with chest pain, dyspnea, edema, and fatigue. And the common causes are infections, which can be viral or bacterial, including tuberculosis in this environment, inflammatory conditions, including rheumatoid arthritis, and of course, malignancies. Many malignancies can cause pleural effusion, and pericardial effusion. And for pericardial effusion, Beck's triad has often been described, which is hypotension, low volume pulse, okay, and muffled heart sounds, okay. But this is seen only in a minority of patients, okay, and we should not try to think that because the Beck's triad is not complete in a particular patient, he or she is unlikely to be suffering from a pericardial effusion. No. Okay, we should also look for pulsus paradoxus while checking the pressure of the patient. And Edward sign is also important. We should check for dullness in the left lung base, which is often caused by the enlarged pericardial space compressing on the left lower lung lobe and causing some sort of consolidation there. The investigations that are important in the patient presenting with pericardial effusion includes a chest X-ray, ECG. A chest X-ray, of course, often shows us a dilated heart, enlarged heart shadow, usually with a double border, which is often difficult to see. Other investigations that are important include an ECG, which can show us low voltages. The voltage is usually said to be low if the height of the QRS complex is less than 5 millimeters in the limb leads and less than 10 in the precordial leads. Okay. Of course, the diagnosis is also on the ECG. We can also find what we call the electrical alternance. Okay. The electrical alternance shows you the QRS complexes swinging axis along the baseline. Okay, and it's usually due to the heart shifting from side to side within the pericardial sac. The echocardiography is important, and of course, that's the diagnostic test for a pericardial effusion. And the treatment is by draining the effusion if it's significant enough, and by treating the underlying cause. I need to mention that the importance of the echo is actually very important as well in determining whether a patient is in tamponade or having imminent tamponade, and that is by using it to assess for changes that shows that the right side of the heart is being compromised by the pericardial effusion. Okay, so hello. Okay, so pleural effusion, of course, is also a very common cause of shortness of breath. And we all know that pleural effusion is accumulation of fluid in the pleural cavity. The things that will point us to pleural effusion being a very likely cause of shortness of breath in a patient will be pleurisy, especially in the initial phase of the illness, and then examination findings often give it away, including absent breath sounds in the affected region with a stony dull percussion notes. If the effusion is large enough, we may be able to pick a tracheal deviation at the beginning of examination of the chest. And of course, the cause of pleural effusion is quite variable, okay, and it's often classified into transudate and exudative effusion. The transudates are listed here: heart failure, renal failure, cirrhosis with hepatic hydrothorax. Of course, there's a lot of them more. And the most common causes of the exudative effusion includes infections like pneumonia, tuberculosis, inflammatory conditions, pulmonary infarction like we have in pulmonary embolism, and in malignancies as well. We should remember that before effusion can be picked clinically, it usually has to be quite large, but you can pick even very little amount of effusion with your chest X-ray. When you see the meniscus sign, it means that there's over 200 mils of effusion there. A chest ultrasound scan is even more sensitive in picking pleural effusion than a chest X-ray, okay? But those amounts of effusion will likely not be the cause of the dyspnea, even though aspirating and analyzing even such small effusion can be helpful diagnostically. Okay, and the treatment for pleural effusion is simply by drainage. If the effusion is significant enough, usually it's thought to be significant enough if it's occupying up to a third or half of the thoracic cavity on one side. Okay, and by the time it's able to cause mediastinal shift, it's often significant enough. But it's important to treat the underlying cause, otherwise the effusion will be recurrent. Okay, so I'm sure we all know acute severe asthma as a cause of shortness of breath, and many people that present with shortness of breath from asthma have actually been diagnosed before. Okay, so those are usually straightforward. Okay, and the story is usually one of episodic symptoms that is usually worse at night and worse in certain seasons. Okay, for example, in Nigeria, worse when the seasons are changing. Okay, and on examination, typically we can see features of obstructive airway disease, mainly presence of bronchi. Okay, it's very important to try to do a peak flow rate assessment for this patient when they present, because it helps in assessing the severity of the asthma, of the acute severe asthma, and it's part of the criteria for life-threatening asthma as well. So if you can do a peak flow rate for the patient at presentation, it's good, and it also helps to monitor improvements and recovery. Okay, chest X-ray is not really useful in making a diagnosis of asthma. Okay, but if the situation is not clear-cut, it can help us exclude differential diagnosis or complications such as a pneumothorax. Okay, and of course, we know the treatment for acute severe asthma, the person should receive nebulized bronchodilators, intravenous, then oral steroids, oxygen therapy, IV fluids. If there's anything that suggests any ongoing infection, we should treat, and we should monitor the patient. And of course, any patient that has been admitted with acute severe asthma should have inhaled corticosteroid as part of the inhalers on discharge. Okay, so I'll briefly talk about exacerbation of COPD presenting with breathlessness. Even though we are focusing on COVID-19, the reason why it's important for us to go through this spectrum of conditions that often present as dyspnea is that where we're seeing a patient with breathlessness, we're not just focused towards one side. You're not focused on COVID-19, you're not focused on heart failure, you're not focused on COPD. You have a broad mind, okay? And then we can tease out the differential diagnosis and the most likely diagnosis based on our clinical evaluation of the patient. So now talking about COPD, usually the patients are older adults, like we all know, and most often the patients will have had some background history of a productive cough that took a while to go away with some shortness of breath. They will have had spells of that in the past, even that they treated even without visiting the hospital as well. Okay, so if you get that in the history of that of a older person, you should be alert and you should be thinking towards COPD. Okay, and on examination, we should look for features of hyperinflation, which I mentioned earlier. Can include a barrel-shaped chest and can include hyperresonant percussion notes. Okay, we should also look for features of airway obstruction, which can be revealed as forced lip breathing, tracheal tug, rhonchi. Okay, they can also have finger clubbing. Apart from making a diagnosis of COPD or its exacerbation when it's happening, we should also look for features of Pulmonary, because that will have to be treated in its own right. Okay, and presence of raised JVP, presence of pedal edema can suggest that this COPD is complicated by Pulmonary. Okay, of course, most COPD exacerbation are associated with infections, even though not always, but they are often associated with infection. Okay, and the investigation that is important to do for such patients includes a chest X-ray, in which we look for the typical features of hyperinflation of the lungs and narrowing of the mediastinum. Of course, this spirometry is critical for the diagnosis of COPD, in which we want to demonstrate an obstructive defect that is not fully reversible on bronchodilator testing. Okay, we should also do arterial blood gases, which will tell you how well compensated this patient's COPD is. And an echocardiography is also important in teasing out differential diagnosis one, and of course in identifying any pulmonary complicating this person's COPD. Treatment, we are all familiar with that. As much as possible, bronchodilators for someone presenting with COPD should be nebulized. Of course, in this COVID era, we're wary of nebulization and the patient should be encouraged to nebulize at home, but we'll talk about later along the line. Also, the role of short-acting beta agonists, muscarinic agonists, and the long-acting versions and the inhaled corticosteroids are important. Expectorants often help in COPD exacerbation, and oxygen should be used if the person is hypoxemic, but of course it should be done cautiously. We should make sure that there is no unacceptable rise of the partial pressure of carbon dioxide when we are giving oxygen to patients with COPD exacerbation. Of course, this again is in the setting of monitoring arterial blood gases. It's also important to treat any concurrent or triggering infection. As I mentioned earlier, infections are a common trigger for COPD exacerbation. And we should watch out for type 2 respiratory failure in patients with COPD exacerbation, especially the ones that is being treated with oxygen therapy. Usually when we are treating patients with COPD, with established COPD with oxygen therapy, usually we aim for the oxygen saturation to be between, when we are giving oxygen, we try to keep the oxygen saturation to be between 88 and 92. So we don't aim as high as possible. Of course, one can get the oxygen saturation a bit higher than this, but only if we are monitoring the blood gases very well, which, as I said earlier, is often difficult in this environment. If the partial pressure of carbon dioxide is going up even before we can correct the hypoxia to a safe range, of course, we should consider non-invasive ventilation for such people, and it should be done very early because the outcomes are better when we ventilate early rather than when it's done later. Okay, so I think I've gone through the very common causes that can bring the patient dyspnea to your office early. I did not mention the psychogenic one again, okay, but we should be aware of that more commonly in young people. And as I said, it's a diagnosis of exclusion. It should be seen to have gone through all this process and the investigations before we say that someone's shortness of breath is likely from panic episodes or from anxiety. So that's a diagnosis of exclusion, and we should do our due diligence before labeling someone's condition to be that. Okay, So in an emergency setting, if a patient is brought into the emergency room with shortness of breath, which is a very common scenario actually, of course, we should go through the ABC of resuscitation, assessing the airway, looking at the patient's breathing, assessing the circulation, we should look at the vital signs, and of course, I believe that for all of us in our practices now, that vital signs, the oxygen saturation is part of the vital signs, and we should know that early, okay? It's not until someone is getting worse that we should start knowing what the oxygen saturation is. And until the oxygen saturation is demonstrated to be good enough, the person should be on supplemental oxygen, okay? And we should know that even while we are yet to make a definitive diagnosis, supportive treatment is often possible for a patient presenting with dyspnea, okay? And it's not uncommon for a patient to be intubated or commence on non-invasive ventilation even before the specific cause of the shortness of breath is recognized. Okay, so in any patient presenting with dyspnea, we should assess for hypoxia, okay, and that is most easily done with the SpO2, with the SpO2 monitor. If the SpO2 is normal, it's unlikely for the person to be hypoxic, okay, but we should know that there are exceptions and caveats to this. For example, in someone with carbon monoxide poisoning, the SpO2 can be normal for a long time on, whereas the person is actually having tissue hypoxia. So that's an exception to that. But in a patient with reduced oxygen saturation, as much as possible, we should try to do the blood gases. I highlighted here that waiting for cyanosis or restlessness to used to say that someone is having low oxygen saturation is not good, because that will likely be a late feature, and by the time we're starting to intervene for such a person, it may be too late already. And it's possible to estimate the partial pressure of oxygen from the oxygen saturation of the pulse oximeter, okay? Of course, it's not terribly reliable, but we can get an index of it from that. And it is said that when the oxygen saturation is getting to 90, the partial pressure of oxygen is around 60 millimeters of mercury. By the time it's falling to 80, is at this lower right corner of my slide. By the time it's falling to 80, the PaO2 is going to around 50, and just like that, okay? Of course, we know that such extrapolation especially is unreliable if the SpO2 is above 95, and it's unreliable when it's below 70, okay? But you can have a good idea of the oxygen saturation for that, especially if you're trying to calculate the P/F index, okay? And this index, this partial pressure of oxygen over a fraction of inspired oxygen, can give you an index of hypoxemia, because it reflects how much oxygen is in the person's system compared to how much oxygen the person is inhaling, or that you're giving the person. Normally it should be above 500, okay? We know that, for example, for ARDS, by the time it's less than 300 is mild, less than 200 is moderate, and by the time it's less than 100 is severe, okay? So by the time someone is having P/F of less than 500, there's some extent of hypoxia that is going on. I can show us how to calculate this later. The FiO2 is just inputted as a decimal, a fraction. So if it's oxygen on room air, which is about 21% oxygen in room air, it's entered at 0.21, okay? And you just put in the partial pressure of oxygen in millimeters of mercury as the numerator. Okay, so let's go on. In assessing a dyspneic patient, it's not only important to assess for oxygen saturation, which our pulse oximeter can give us an index into. We should also assess for hypercapnia, okay, which is carbon dioxide retention. And carbon dioxide retention, eliminating carbon dioxide is a ventilatory function. That is, it just depends on air moving in and out of the lungs. And when air can no longer move in and out of the lung, either due to airway obstructive issues or problem with the neuromuscular apparatus that moves the chest wall, it leads to what we call a ventilatory failure, and carbon dioxide can build up. And importantly, like I said earlier, this cannot be assessed with the pulse oximeter, okay? Even though there are some special oximeter, pulse oximeters that can pick carbon dioxide, okay, but they're not so common. But at least the standard pulse oximeter cannot tell us if a person is retaining carbon dioxide or not. And that's part of the reason why if we need to use oxygen for a patient with COPD, if we are giving more oxygen than we should, the hypoxia will initially correct, okay? But if carbon dioxide builds up, the patient gets obtunded, and then the hypoxia will worsen secondary to that, okay? And even though we in this part of the world, we can pick carbon dioxide retention clinically, okay? But even though we can do that to some extent, the clinical signs often occur late, okay? So it's always better if ABGs can be used to pick the progression of the change of, that's the rise in carbon dioxide, even before these symptoms start to occur. Okay, but the clinical signs that can occur if someone is retaining carbon dioxide can include headache, features of vasodilatation like headache and bounding pulses. They can also get drowsy along the line, and then they can develop a flapping tremor as well. And in patients that are on a mechanical ventilator, the mechanical ventilator actually usually shows this end-tidal carbon dioxide level, which can give you an idea of how much, if there's carbon dioxide retention or not. But of course, these patients are already on treatment, because the treatment for carbon dioxide retention is often mechanical ventilation, even though, of course, other things that can be done to improve airflow and support the neuromuscular structure can be done. And these are things like propping up the patients, managing the airway well, treating any bronchospasm, particularly in someone with obstructive airway disease, and treating any neuromuscular disease like myasthenia gravis, etc., before patient is ventilated. Okay, so I have 2 chest X-rays here, and I don't know, I would like some of us to try to interpret this X-ray. So we have 2 X-rays here. One is A, the other one is B. Please, can someone attempt, please? Okay, so we have 2 X-rays here again. One is A, the other one is B. Okay, I think we're a bit short of time, so I won't go into the details so much. Okay, someone suggested that the B X-ray shows hyperinflation. Okay, look more at the B. Look more, compare the right hemithorax to the left hemithorax. Okay, yeah, so someone has picked my B question. The B1 shows pneumothorax in the left hemithorax. Okay, so you can see that it's almost entirely devoid of pulmonary markings. Okay, and that's how pneumothorax looks. And it's actually very easy to mix, especially the quality of the film is bad. Okay, so yes, there's a bit of hyperinflation on the B X-ray, but it's primarily pneumothorax. Okay, and so, but because of the hyperinflation, if you were to hazard a guess as to the cause of the pneumothorax, it's probably from COPD that caused the pneumothorax. Okay, but this all long-filled air is this all left hemithorax is devoid of vascular markings. Okay, so we are right about the A X-ray. It shows features of pulmonary edema, and in this case, it's cardiogenic pulmonary edema because you can see some upper-lobe diversion and some cardiomegaly. Okay, so I think that's impressive. I'm happy about that. I have to move fast now to get to the COVID section. Okay, but I'll just mention briefly now that the other investigations as listed here, I think I've mentioned most of them already. Okay, so I think we'll just move on. Okay, so here we are. Okay, so we know that there are many causes of dyspnea. We've been seeing people with dyspnea for years now, and we've been treating them, okay? But now we have this pandemic here at our hands, and it makes things much more difficult. Basically, it changes the landscape. We know that many patients with COVID-19 will be asymptomatic, okay? But amongst the ones that will have symptoms, They can come with a diverse range of symptoms. And this chart from on the left side of the screen actually shows the typical symptoms of COVID-19 from the Chinese series. Okay, and we can see that fever is the commonest. With this list, shortness of breath is actually the fifth common symptoms, about 20% of the patients. And of course, we know that it's about 20% of the patients that will be very sick. And I think the very sick is defined from this 20%, okay? About 20% will be very sick, that is, they have shortness of breath and they will likely require inpatient care, and of which 1 out of 4 of those that are very sick will require ICU care. Okay, so of course, as the pandemic is spreading, it means that a higher proportion of the people with dyspnea, more and more proportion of the people with dyspnea will actually be COVID. Okay, but how can we tease this out from all the other causes of dyspnea that we've been talking about since? I think that's the challenge that many of us clinicians will have in this time that we have. Okay, so again, among the patients that require hospitalization, I'm not saying in Nigeria because Nigeria, we are still admitting a lot of patients without dyspnea just so that they won't spread it at home and they won't spread it in the community, okay? But globally, the major indication for hospitalization in patients with COVID is actually more severe sickness, and most of them will have some extent of dyspnea, okay? So dyspnea is common among the COVID patients that require hospitalization. Looking at the common trajectory of symptoms in them, cough and fever often starts before dyspnea, okay? So the cough and fever starts, many of them, there's among patients that will have symptoms, cough and fever starts, and many of them will just recover from that cough after a while, okay? But in people that will develop dyspnea, the dyspnea often starts in the second week of illness, that is around the 7th to the 10th is when the dyspnea will start. And that means, I'm sure we can remember Boris Johnson's case, for example. He has had a cough and he has had some mild symptoms for a while. It was actually later along the line, quite a while after he has notified the public that he tested positive, before dyspnea started, okay, and he required hospitalization, etc. Okay, so this dyspnea starts later among those with severe symptoms. And the fever is very common among the patients. Like you can see in this series, almost 90% of the patients, so almost 9 out of 10 patients will have some fever, okay? Even though fever can be absent in the early stage, okay? And then by the time you now pick the patients that will end up developing dyspnea, by the time they have shortness of breath, most of them will have fever, okay? And that means that in the absence of fever, it makes COVID-19 to be less likely. So if you have someone with shortness of breath and then there's no fever at all, it makes COVID-19 less likely. Now, it doesn't make it impossible, okay, but it makes it less likely. And we should be aware of anti-inflammatory agents and antipyretic. So many of them could abuse paracetamol and NSAID, hydroxychloroquine, or even chloroquine, which could have dampened the fever and make the fever to be missing from the equation, okay? But the honest patients will usually be able to give you that, okay, they had fever. Also be aware that many of them often describe fever as malaria feeling. So many of them could tell you that, yes, I'm having cough and dyspnea, I don't have fever, even though I treated malaria 5 days ago or 4 days ago, okay? COVID-related dyspnea can present like that, okay? But as I said, in the absence of fever, it actually makes COVID to be less likely in a patient presenting with dyspnea. When a patient with COVID is presenting with dyspnea, there is established pneumonia already. That is, there's established changes in the lungs already by the time they're having dyspnea, okay? Also at that time, the oxygen saturation is almost always low, okay? So that means if you have a patient with dyspnea and then the oxygen saturation is fine, again, it's probably not COVID, but of course, we should continue to have a very high index of suspicion. It's also said that the chest imaging is abnormal in COVID-associated dyspnea. In fact, many asymptomatic patients with COVID have an abnormal chest X-ray. That's without any symptoms at all. They have an abnormal chest X-ray. The ones with mild cough and fever without shortness of breath, many of them have an abnormal chest X-ray. So by the time they're having dyspnea, with the other symptoms they're having. The chest X-ray, chest imaging, whether X-ray or CT scan is almost always abnormal. Okay. We should also note, and this is a slight catch, that the shortness of breath in COVID patients initially is often on exertion. That is, they tell you that they're fine. That is only when they move that they are experiencing shortness of breath. And many people can actually describe their shortness of breath as just tiredness. Okay, so we should put that in mind. And like atypical pneumonia, don't forget that the cause of atypical pneumonia that we have always talked about before are things like viral causes and atypical bacterial organisms like chlamydia. Okay, so like atypical pneumonia, true to the book, patients often look better than their imaging or chest or oxygen saturation. So you do the patient's oxygen saturation, you see 86 or 88 there, and you look at the patient just looking at you talking, not so breathless at rest. So that's a common picture, okay? But we should not underestimate the pneumonia or the lung disease in such patients just because of that, the way the patient looks. It has often been described as such patients, usually they can deteriorate within the next few days and pass on, okay? So again, obviously, as we've said many times during this presentation, everybody that presents with dyspnea should have oxygen saturation done. Okay, so the next question now on our list is that now, where are the other causes of dyspnea? If we say that during this pandemic like this, most cases of dyspnea will be assumed to be COVID-19 until otherwise proven. That's what most hospitals or clinics will be practicing now, which is rightly so, okay? But the sad consequence of this is that many patients with non-COVID dyspnea will be denied early care of other life-threatening conditions. I think it was in the news last week or so that a person in this Abuja actually went to a private hospital with what was thought to be acute severe asthma, and because the healthcare workers did not have PPE there, they were busy looking for PPE until the person died. Literally, that's what was said. And the said person was a non-asthmatic patient. Now, whether this was indeed an asthma exacerbation or whether it was COVID, it's difficult to say. But the truth is that ischemic heart disease, pulmonary embolism, acute pulmonary edema, heart failure, pneumothorax will not disappear into the thin air because COVID is in town. No, okay. And there's a way we can try to avoid this excess mortality. Of course, it's important to have a very high index of suspicion for COVID and also for the other dyspnea-related emergencies. Okay, we should have a very high index of suspicion, and we should, of course, we should use our clinical thinking rationally and critically. Go to the history, examination, and of course, we should formulate our differential diagnosis based on that. And sometimes there are some precautions, extra precautions we can take so that we can do this effectively. I'll go into them later. But of course, diagnostics with rapid turnaround time will actually help reduce all these excess mortalities. Okay, and that's like rapid tests for something like the COVID, which of course is not available now. But you can imagine that if someone had dyspnea and then you're worried whether it could be COVID, it's not COVID. If you could just do a rapid test like the way the HIV tests come in kits, if you could do a rapid test like that and exclude COVID, you can go ahead and treat the patient you can go ahead and fully evaluate your patient and treat for the real condition, and that could have helped reduce the excess mortalities. But sadly, the available tests for COVID-19 now, they don't have a rapid turnaround time, and some of them, the turnaround time is days, like 2 or 3 days, of which someone presented with pulmonary embolism or acute pulmonary edema would have died before the doctor was bold or brave enough to approach the patient and treat the patient. Of course, the excess mortalities can also be avoided by taking standard precautions. If, of course, based on the level of exposure and the level of risk, going from things like face mask, which is standard now, to goggles for high protection, of course, to the full PPE in certain situations in which there's very high risk of aerosol dissemination and transmission of infections. Okay, It's especially important to pay attention to patients with existing cardiopulmonary disease, okay? And the reason for this is that two things. Number one is that patients who have existing cardiopulmonary disease, who are often the dyspnea patients, they are more likely to have COVID. Basically, that's so the rate of infection in them is higher. Apart from they're more being likely to have COVID, they are also more likely to die from it. So it's a two-pronged thing now, okay? They're more likely to have the condition and be hospitalized from the condition, and of course their mortality is higher. And we can see that these conditions increase the likelihood of being hospitalized for COVID. So this diabetes mellitus, chronic lung disease, that's someone that is likely to present with dyspnea on his own merits. Okay, someone with cardiovascular disease, immunocompromised patients with CKD, hypertension, and pregnancy. Okay, and here we can see that, we can see that patients with cardiovascular disease have a very high mortality from this COVID pandemic. And it has been suggested actually that many of the excess mortality, yes, is from the COVID, but many of them is from the underlying condition that they did not get enough care from because of their underlying COVID. So I'll just go for examples here now. The patient with cancer, for example, person is already labored by a very serious illness already, now having COVID. Is it very likely that the cancer care will continue the way it should while they're experiencing the COVID? Not really. Many patients have had to stop chemotherapy and have to stop other treatments because of the pandemic generally, and even because of their condition specifically. Don't forget that treatment of cancer, for instance, is immunosuppressive in nature. And look at the other conditions such as chronic respiratory disease, diabetes, cardiovascular disease. So the excess mortality in these patients is as a result of the COVID, one, but also as a result of the underlying condition that is unlikely to receive enough or adequate care because of the pandemic and because of the COVID that is ongoing. Okay. So the dyspnea in COVID, of course, the major mechanism is from ARDS-like changes. That's adult acute respiratory distress syndrome-like changes. And some things have been, even though some other potential mechanisms have been discussed or described, okay, but based on the available autopsy series and all the documented evaluation for now, the changes in the COVID lung are the typical changes, of course, with some slight differences, but they are most consistent with ARDS-like phenomenon. And the things that have been shown are this hyaline membrane formation, immune cell infiltration, particularly macrophages and monocytes, okay? Also, there has been focal desquamation of the alveolar epithelial cells, interstitial vascular congestion, and microthrombal formation. Also, there are areas of focal pulmonary hemorrhages and viral particles as well. Another factor that contributes to the dyspnea in COVID is myocarditis. Okay, myocarditis generally, we should put in mind that the causes of myocarditis are predominantly viral in nature. Okay, so myocarditis, the common viral organisms that have been described includes Coxsackie virus, especially B, Epstein-Barr virus, cytomegalovirus, parvovirus, are all known causes of myocarditis. So it should perhaps not be surprising to us that we're having a viral cause of pneumonia, and it can also cause myocarditis as well. Okay. Now, the mechanism of myocardial injury in COVID is a combination of direct viral infiltration, either from lymphatic or hematogenous spread, then also the exaggerated inflammatory response, which has been termed cytokine storm, is also thought to contribute to some extent to the myocardial injury. Of course, this is something that information is coming more and more on, and it has not been fully delineated. Okay, but myocarditis among patients with COVID that are dyspneic, myocarditis has been said to occur in up to 20% of such patients. And the things that can, in someone with COVID-related pneumonia, the things that can suggest myocarditis were things like hypotension, even though we should remember that in the late stage of sepsis syndrome, which occurs in COVID as well, sepsis syndrome can also cause hypertension in them on septic shock. Okay, but apart from that, hypertension can be a pointer towards myocarditis, especially if the hypertension is associated with elevated JVP, gallop rhythm, fluid retention, both in the lungs and in the pedal, and with the pedal edema. And of course, if the myocarditis is severe, we can see some extent of cardiomegaly on chest X-ray. Okay, so if you see all those things, we should suspect that this patient with COVID may also be having a myocarditis. Okay, and some tests usually can confirm this. If you see elevation of troponin and CKMB markers, also if there's elevation of beta natriuretic peptide, which tells you that there's some cardiac distension and cardiac compromise. Okay, so if we have this elevation of cardiac markers, it really suggests to us that there's associated myocarditis in such patients. Of course, we know that these biomarkers are less reliable in the presence of a sepsis syndrome, okay? But if they're quite elevated and if the clinical scenario is consistent, it's most likely that the patient is having myocarditis. And of course, the implication of this is that the myocarditis in such a patient may warrant specific treatment, of course, depending on the amount of dysfunction that we can demonstrate in such a patient. Many often there may be some ECG changes which are often non-specific, like low voltages, some ST segment changes, and ectopics. And echocardiography can show us reduce movements and reduce, depending on the severity of the changes, we can have regional wall motion abnormalities and reduce contraction and reduce systolic, plus or minus diastolic function. Many patients with COVID who actually presented with chest pain and shortness of breath and had elevated cardiac markers, especially troponin and CKMB, have actually had coronary angiography done, and they found that the coronary blood vessels were entirely normal in them. Okay, so we should be wary of this, and elevated troponin in a patient with dyspnea, and chest pain should make us, of course, consider COVID with myocarditis. Okay, and before coronary angiography is considered for such patients, we should consider COVID. And I know that some hospitals in the US will actually standardly do a COVID test for such a patient before doing a coronary angio. Okay, so how should we approach these patients? With all that we know now, how should we approach these patients? Who are the potential patients with COVID? First of all, we know that every patient with dyspnea, with shortness of breath, is a potential COVID patient, even though there are tons of other diagnoses that we've been seen before and we'll continue to see. And we don't want to mix up those patients. Of course, not just everybody with dyspnea is a potential case, even every patient, everybody, okay? And if we take standard precautions early, I think we'll be able to more confidently evaluate these patients and give them the appropriate investigations they need, so that we can tease the differential diagnosis out, and of course, we can avoid the excess mortalities. Okay, so the things we can do in doing this teasing out includes a pre-consultation screening. Okay, in many hospitals, on entering the hospital, the patient actually fills a checklist to see if some of the parameters are there. So things like presence of fever, cough, shortness of breath, and of course, depending on how much is positive and how likely COVID is in such a patient, such patients should be directed to a designated facility, which will be likely an NCDC accredited center. Okay, such pre-consultation screening can also be done on phone. Okay, I know that they did this a lot in the US, such that if a patient comes to a healthcare facility, patient calls the front desk of the hospital and he actually has a little chat with the doctor about the symptoms. Okay, and if it's a dyspnea patient that the doctor wants to see in the facility, the patient comes in, and if the patient that is to be redirected to to an accredited COVID center, the patients will be redirected. Okay, so that pre-consultation screening is very, very important for if you're going to see a dyspnea patient in your facility. Of course, if the pre-consultation screening suggests that there's likely a pneumonia going on in the context of this pandemic, every pneumonia can be a COVID pneumonia. And of course, the patients preferably should be treated from home if possible. If cannot be treated from home, should be admitted in a context now, NCDC accredited facility or NCDC site, okay? In patients that are not really likely to be COVID, then they can be seen when it's not so likely to be COVID. Maybe from asking the patient's question, I think this is likely heart failure. The patient has been having shortness of breath for 3 months and repeated edema, dyspnea on exertion, even though he has some cough or he has no fever, but this is not acute, for example. So if I have that kind of scenario, I would think that, okay, this is unlikely to be COVID. And of course, that patient can be seen in a regular healthcare facility. Of course, even while doing that, there should be basic PPE and basic hygiene measures, okay? So both the patient and the healthcare worker should be wearing face mask. There should be healthy distance between the healthcare practitioner and the patient, okay? So at least 6 feet between the patient and the doctor. And of course, when examining the patients, it's important to take extra precautions to make sure that social distancing is maintained as much as possible, okay? And that you stay fairly clear of the exhaled breath of the patient, okay? And some of the things that has been practiced, including preferably using a digital stick to take the blood pressure. So just give the patient puts it on himself and presses, okay? If you need to adjust it, you can just come briefly to adjust it. But as much as possible, nothing that makes you in very close contact with the patient for more than 5 minutes and as little as possible. So those are some examination precautions that can be taken. Also, of course, it's standard when examining such patients, if you're listening to the breath sounds, for example, it's good to listen posteriorly and the patient faces, you stand at the back of the patient and listen posteriorly so that the patient is breathing forward and the patient is definitely not breathing into you. And also, if you have to auscultate the, if you're auscultating the heart, the patient should be looking in the other direction so that you just approach from this side and the patient is not breathing into you. If anybody is breathing into anybody, it's probably more likely you breathing into the person. Of course, you're wearing a face mask, so the risk of transmitting anything should be minimal. Also, in such examination setting, you should put consideration for the airflow. And the preferred kind of airflow for such places are the negative, such that the wind should be blowing away from the physician towards the patient and then out, okay? So that is important to stay in such a direction. So for example, if there's a fan or an air conditioner between the physician and the patient, the physician should be closer to the fan so that air is going away from the physician towards the patient rather than the other way around. Of course, such places should be well ventilated, and if it's a negative pressure room, preferably. Okay, so we're almost done. Just a few more slides, and the key decisions that need to be made has to do initially with the site of care. Okay, and many patients, actually even with respiratory symptoms, will qualify for outpatient care. Okay, so if the patient is not in respiratory distress, the oxygen saturation is good, and the diagnosis is clear, and it's not an emergency, okay, the patient will qualify for outpatient care. Okay, of course, we should also know the patients that need to be referred. So patient with a clinical pneumonia that requires an inpatient care usually should be referred to a COVID-19 treatment, accredited COVID-19 treatment center, okay, which for now in Nigeria includes the NCDC sites, at least in Abuja, okay. Also, specialist cases should be referred early for specialist care, things like ischemic heart disease, pulmonary embolism, and decompensated heart failure should be referred for specialist care, okay. And the patients that need the people that need inpatient care, especially people that meet this criteria, people that have acute shortness of acute symptoms, diagnoses that are emergency diagnoses, just like the things I listed here, the pulmonary embolism, myocardial infarction, etc. People with hypotension or with hemodynamic instability, cyanosis, altered mental status, or when the diagnosis is unclear, those are the things that can influence you to offer the patient's initial inpatient care. Of course, remember that for pneumonia, the COB65 scoring with a score of 2 and above is an indication for inpatient care. Okay, so apart from the other precautions we need to take, I think I've mentioned this, both the patient and the staff should wear a face mask at all times, okay? The practice of people removing their face mask when they want to talk or when they want to cough, of course, should be avoided as much as possible. And of course, we should take the standard hygiene precautions, maintaining a safe distance between the healthcare provider and the patient and other things I mentioned in the previous slide. As much as possible, we should avoid aerosol generating procedures, except in designated areas. And this should actually be minimized as much as possible. We should not forget that the PPE, even the full personal protective equipment, is not 100% protective, of course, judging by the number of healthcare workers that have been infected, even in the most sophisticated and the most disciplined centers, okay? So we should avoid the aerosol generating procedures as much as possible. And then if we must do them, we should do them only in designated areas. And of course, with the necessary personal protective equipment. So those high aerosol generating procedures are things like nebulization, high flow oxygen by nasal cannula. So if you're turning the oxygen to more than 6 liters per minute, it is generating aerosol. Don't forget that the oxygen is going through the nostrils and will be forcing some air out. It's just natural. It forces some air out, and those air will contain things from the nasopharynx of the patient. And of course, if the person is a COVID patient, a lot of COVID viruses will be in the atmosphere in that place. So by the time it's getting to more than 6 liters per minute, it is high flow and it's generating aerosol. Also things like chest physiotherapy, even cardiac compression from cardiopulmonary resuscitation, suctioning, humidification of the hair, non-invasive ventilation like the CPAP, intubation, bronchoscopy are all considered to be high aerosol generating procedures. I think we need to speed up. There are indications for ICU care. Well, I think I'll skip this, okay? There are indications for ICU care in the COVID patient, but it applies to non-COVID patients as well. But most importantly, if the patient is desaturating on 50% oxygen, the person needs ICU care. And of course, if the respiratory rate is greater than 40, the person needs ICU care, okay? The remaining on the screen applies as well. Okay, we should also know that the patients with dyspnea, including patients with COVID, can often present with respiratory failure. And the respiratory failure in people with COVID is actually more often to be type 1 respiratory failure with predominantly hypoxia in the, and of course, there'll be absence of hypocapnia. So CO2 is usually normal, of course, until the tail end. Of course, we know that when we talk about respiratory failure being type 1 and type 2, type 1 is only hypoxia, type 2 is hypoxia with raised CO2, that's with carbon dioxide retention. But even type 1 can progress to type 2 because when someone becomes hypoxia for long, invariably the person will become drowsy, and of course, won't be breathing well, and carbon dioxide will accumulate, okay? But importantly, the primary respiratory failure in COVID is a type 1 respiratory failure. Okay, so generally speaking again now, the management of someone presenting with dyspnea is basically treating the underlying cause, which is widely variable, okay? But also important is the supportive treatment. And supportive treatment is critical for patients presenting with dyspnea. And it's especially so, especially in this COVID era in which there is no definitive treatment for COVID, for example, okay? And so oxygen therapy is important through nasal cannula, face mask, rebreather bags, or most optimally, Venturi masks. Okay, of course, optimal positioning is also important in managing a patient with dyspnea, okay? We know that many dyspnea patients would prefer to sit up. Optimal position is for a patient with heart failure is 45 degrees, okay? And we know that for patients with ARDS, many times proning proning such patients helps, which I'll go into very briefly later. Okay, if there's any bronchoconstriction, which is evidenced by presence of rhonchi on examination, the patient should be given bronchodilators, either in form of nebulization, inhalers, or even the theophylline like aminophylline. Of course, we should pay attention to secretions in such patients, and it should be cleared by suctioning. Okay, so assisted ventilation is often needed, particularly if there's either hypoxia or hypercapnia that is not responsive to the initial management. Okay, we should other indications for assisted ventilation includes protecting the airway in a patient that is obtunded, or if we expect that the patient is gradually deteriorating and we don't want to wait till the last moment before we offer the patient assisted ventilation. Okay, I won't go into this because of time. Okay, but this is just a broader list of indications for assisted ventilation. We should know that when we are offering someone assisted ventilation, it can be non-invasive or invasive. Okay, the only difference between non-invasive and invasive mechanical ventilation is the endotracheal intubation. Okay, so if you have to put a tube in before we ventilate the patient, it is invasive mechanical ventilation. Whereas the non-invasive one, often just written as NIV, is usually through a face mask, and it's often either CPAP, that's continuous positive airway pressure, or the BPAP. Okay, the other peculiarities of COVID and ARDS is that in ARDS generally, and that includes COVID, we use fluid sparing regimens. That is, you give as little as possible IV fluids that you have to give. Okay, mostly they will still require IV fluids, but you give as little as you have to give. They will still require, because these are breathless patients, they're likely losing a lot of fluid through their expiration. They're usually febrile, so they're losing more intensive water loss, and they're very sick, so they may not be taken orally as much as possible. Okay, but we don't want to give too much fluid because of the capillary leakage in the lungs that characterizes ARDS. Because if we're giving too much fluid, there'll be more leak into the lungs will become wetter, and the pulmonary edema will worsen. Also, prone positioning is also important, and this helps recruit the posterior inferior, the alveoli and the posterior inferior region of the lungs. Okay, because when there's non-cardiogenic pulmonary edema, when there's ARDS, the lung is basically wet, and the wet lungs sits on itself and creates a kind of weight for the lowermost and posteriormost part of the lung, such that it worsens atelectasis, such that the alveoli in these areas are unable to expand because of the weight on it. But if we prone such patients, gravity pulls the fluid to the other side, and then the alveoli are able to expand better. Also, we've talked about avoiding aerosol generating procedures. Also, the prognosis usually obviously depends on the specific underlying cause and its severities. Okay, but like we can see in COVID, age and comorbidities play an important part in determining the prognosis of a patient presenting with dyspnea. In our climes, our age is younger, so it makes people speculate that our outcome may likely be better than them because of the slightly younger age. Okay, but the unavailability of advanced life support therapy will likely counterbalance that. Okay, and that makes it look almost neutral. Okay, but age and comorbidities, higher age and more comorbidities worsen the prognosis, whereas availability of advanced life support therapy improves the outlook. Okay, we should remember that people with comorbidities are the ones that have the highest mortality among this COVID epidemic. But we should also remember that among people requiring mechanical ventilation, the mortality is about up to 50%. Okay, so in the Chinese series, it was actually up to more than 70%. Okay, but in the American series, it's between 25 and 50%. The 25 and 50% that survive the mechanical ventilation. Okay, of course, there are many prognostic scores that we use in assessing the prognosis of patients with dyspnea and patients requiring ICU care. And those include things like Apache score and the SOFA score. I won't go into that so much. Okay, so now I conclude. We know that dyspnea is a common and often distressing clinical symptom. It's a subjective experience, and people who are experiencing exactly the same thing will actually experience dyspnea in different ways. And even though the possible causes are quite extensive, by doing a careful evaluation, we often can identify the cause of the dyspnea. Okay? Prompt evaluation and intervention, when done, will help us avoid excess mortality. Thank you very much. These are my references.
All right, thank you, Dr. Awofisoye. We'll take questions briefly. I know we've spent quite a number of time. We're also streaming on Facebook, so we'll take questions from both Facebook and from Zoom. If you have any questions, please just kindly put it on the chat or raise your hand if you want to speak, and then I will just unmute you to allow you to speak. If you have any questions, let's have them now. And our panelists are standing by, Dr. Awofisoye, Dr. Iseko, and Dr. Olaliko. We're all standing by to answer any questions you may have. So any questions? Any questions? Yes, any questions? Are there any questions or any things that you have to answer? The video will be available afterwards for you to rewatch. So you can rewatch it at your convenience if you have, if you want to review what was taught. You can always rewatch it. While we are waiting for questions, I will just make a few announcements. Next week, from Tuesday, we'll do hypertensive crisis, diagnosis and management. We'll also do approach to chest pain at the next one. So every 3 days or thereabouts, we will announce a new topic that we'll discuss and share via Zoom. This is from Cardiocare Hospital. It's something that Cardiocare is doing for everyone. And then we'll also do one that everybody has asked about, which is COVID-19 and pregnancy. And our gynecologists will be talking about the effect and how to adjust COVID-19 in terms of antenatal care and what to do and what to look out for. There have been some unfortunate stories of doctors that contracted some things during delivery and other things like that. So we'll also touch briefly on this, on COVID-19 and pregnancy. So just keep watching. We'll also broadcast on all our pages on Facebook, just in case for some people that cannot get on Zoom, but we'll prefer it on Zoom where you can ask questions. We'll also do COVID-19 and pediatrics, and the people from the Children's Hospital, our pediatricians, Dr. Peter and his team, the pediatric cardiologists, will be having their questions ready. We'll be having their team ready to answer questions about COVID-19 and pediatrics in Nigeria. And of course, this is Cardiocare, from where we are broadcasting. Dr. Awofisoye is in the other consulting room here. All of us are there. These are some of the facilities in Cardiocare. With, of course, our cath lab. We do a number of tests, a number of things. Okay, so I will just pick questions. So what is the possibility of an asymptomatic COVID-19 patient transmitting to a doctor? And that's from Dr. Henry Igwe. So I'll just answer that briefly. Yes, the possibility is still very there. Several studies, and of course it's still coming out, several studies have talked about the impact of talking and even breathing on spreading the virus. And that is why it is important for general OPD settings to try as much as possible for both the doctor and the patient to be wearing a face mask. at the very least. I think that is the least that we can do in terms of preventing. You cannot know who it is. That is number one. Number two, as part of the presentation Dr. Awofisoye made, the sitting arrangement of the doctor and the patient should be at least 6 feet apart. That also reduces the ability to transmit. So, and then of course, hand hygiene. Face mask alone don't prevent this. Hand hygiene needs to be performed after removing gloves, after each patient consistently, and the patient also should have done hand hygiene. That way, the chances of transmission will be much, much limited, especially in an asymptomatic presentation. Somebody says, can we do highlight renal and hepatic impact of COVID? Okay, we'll consider that as one of our featured topics going forward for kidney and liver, the impact of it. We'll consider that going forward for one of our topics. And any other topics you want us to discuss relating to COVID or relating to cardiovascular or internal medicine, just let us know, and then we'll talk about that. So we're going to talk about COVID in children and the breathlessness and impact of it on pediatrics. We're going to talk about COVID and pregnancy. We'll talk about hypertensive crisis. We're going to talk about chest pain, but not today, of course, going forward on other days. If there are no other questions, Dr. Awofisoye, do you have anything to add?
There's another question. I can see some questions in the Q&A.
Okay, go ahead.
Okay, yeah. So Dr. John is asking if does non-invasive ventilation, is it useful in the management of COVID-19? And what are the benefits over mechanical ventilation? So yes, NIV is useful in the management of COVID-19. Actually, for every patient with respiratory problems, we should actually always consider NIV before going for mechanical ventilation, okay? Especially in COVID-19, because it is often difficult to wean patients with COVID-19 off intubation and mechanical ventilation because of the high, what we call PEP, that's positive end expiratory pressure. They often require to keep their alveoli open, okay? So they're prone to atelectasis and they are often difficult to wean off mechanical ventilation. So, sorry, invasive mechanical ventilation. So NIV is technically preferred, but the main but is that NIV is aerosol generating, okay? So NIV is aerosol generating, and because of that aerosol generating that happens with the non-invasive ventilation, it puts the healthcare provider at higher risk. And because of that risk, many people have advised that we should, as much as possible, not do NIV for patients presenting with that we're managing for COVID, so to say. So I think that answers the first question. And then the second question is that how does CPAP prevent self-induced lung injury in COVID patients? And the answer to that is that in COVID patients, mechanical ventilation and with intubation actually puts, it causes what we call barotrauma. And barotrauma means putting too much pressure in the lungs, okay? Now, mechanical ventilators have some pressure settings that you can set and some alarms that can actually help us not to put too much pressure in the lungs. But don't forget what I said moments ago, is that they actually require a lot of pressure to keep the alveoli open, okay? And that's that PEEP pressure we talked about, the positive end expiratory pressure, okay? So we actually, both in inspiration and expiration, there's a positive pressure going on in people that require such a high PEEP pressure. And so, whereas patients who are undergoing non-invasive ventilation are not prone to such barotrauma. I hope that answers the question. The last question asked by Dr. John is that what are the criteria to suggest a quality CPAP for a patient with COVID? So what are the, I'm not sure I really understand the question very well, but I think it means that what tells us that we're doing the CPAP correctly for a patient with COVID-19 and that the CPAP is working. Basically, number one, when we are considering CPAP or not non-invasive ventilation for a COVID patient, we should always remember that that there are some criteria that should be met before someone qualifies for having CPAP. And this criteria includes that the patient should be fully conscious, the patient should be able to protect his own airways, and he should be fully conscious, should be able to protect the airways. There should be no facial injuries. The facial mask, because don't forget that the non-invasive ventilation is done by mask, so the mask must fit in very well and snugly. Okay, so if you're giving a patient such, and then you are able to correct the hypoxemia with it, is doing well, and the patient should be continued on that non-invasive ventilation. Okay, but if a patient is getting that and the patient is remaining hypoxemic, one, or you're having trouble with secretions, so you're having to, it's difficult to function when the patient is on CPAP, you're having problem with secretion, the patient's airway is not protected, usually we need to switch to invasive ventilation. I think so that's the way I can answer that. Someone is asking about the incubation period of COVID-19. The incubation period is thought to be between 2 and 14 days. Okay, 2 and 14 days with an average of about 5 to 7 days thereabout, but between 2 and 14 days, generally speaking. Okay, yes, I like this question concerning the cautious use of oxygen in COPD patients. Is it due to burnout of carbon dioxide? Okay.
Let me try and answer that. I think she's asking why are we doing the cautious use of oxygen in COPD? I think that's the question she's asking, and she's already answered it, which is the first part. Trying to switch from the hypoxia drive. Dr. Officer, you get it? You get the question now?
Yeah. Okay, I get the question now. Yeah. So in patients with COPD, the drive for respiration in normal people is due to carbon dioxide. It's carbon dioxide that triggers us to ventilate and do our respiration. Okay, but in patients with COPD, because they've had hypercapnia for a long time, usually hypoxia that triggers the need for the respiration. And by the time you start to correct the hypoxia, usually the respiratory drive reduces and then carbon dioxide accumulates further. So their chronic hypercapnia makes them relatively less sensitive to carbon dioxide, and it's hypoxia that's been triggering them all along. Okay, but by the time you start now correct the hypoxia excessively and dramatically, it leads to worsening of the hypercapnia and of course later worsening of the hypoxia as well. I hope that's fairly clear. Okay, so there's another question here that I've read that invasive mechanical ventilation does not improve mortality in COVID-19. How true is that? It's not really true from the statistics I gave, okay, but it doesn't help that terribly much, that's the truth. Again, from the Chinese series, there was 80, at least the initial Chinese series, there was 80% mortality amongst those that were on, that required mechanical ventilation. That's almost all of them actually. Whereas in the US series was about 50%. I think it was from Washington or somewhere, but one of the earliest ICU series that was released in them. So 20% surviving is not zero, so it's still something, even though it's not as good as we might have hoped. Someone's asking a question.
Let me allow Olise Ozapo to talk. Olise Ozapo has been raising her hand for a while. You can go ahead and talk, Olise. Olise, you can unmute your mic and talk. Or Akao, Aliyu Akao, you can unmute your mic and talk. It seems like you have a question. Your hands have been up for a while.
People actually raised their hand by accidentally.
By mistake. Oh, okay. So, okay, fine. Let's go ahead and answer the other questions.
Okay, the last question I can see here is that for COVID patients who later test negative, Can it recall? The short answer is that we don't know yet. We don't know yet. Okay. So there have been some reports of what looked like. Well, there's been some reports of people who are tested negative and then later tested positive again. But most people think is some redundant leftover viral material in such a person. It is expected that there will be some antibody protection for people who recover from COVID that will cover them for at least a while, but it is not known for certain yet, okay? But the fact that convalescent serum or plasma, that's plasma from people that have recovered, has been helpful in treating people with severe COVID, and this has been documented with some of the randomized trials. So that suggests that there is at least some amount of protection in the serum, which is likely antibody-based, okay, but it's not known for sure yet. So I think that's the way I'll answer that question.
Okay. Good afternoon, everybody.
Hi, good afternoon.
Please, my question is concerning the factors of humidity and weather on COVID-19 transmission and pathogenesis.
Okay. Yes, thank you very much for that question. The truth is that, like for COVID-19, just like for every other organism, certain conditions are favorable and certain conditions are less favorable, okay? So humidity, a temperate weather is favorable, and dryness and heat, hot temperature is not favorable for the virus. So in all the surfaces that they mentioned that the virus can last for so long in, that's in the air for maybe a few minutes to a couple of hours on surfaces, with higher temperature and with reduced humidity, the virus lasts a shorter period on such surfaces. I don't know if you understand what I'm saying. So higher temperature is against the virus, and less humidity too is against the virus, and that it affects the efficacy of transmission. Okay, so transmission is less in sunny areas, and of course it's less in outdoors, is more indoors, more in humid areas, etc. Okay, but the absolute overall effect of that is only time that will tell. Okay, but a study that I checked, that I saw recently, said that perhaps more than 80% of the transmission happens in indoor areas. So the transmission is largely indoors. The outdoor, the wind and the breeze, the UV rays will reduce the efficacy of transmission in such settings.
Okay, thank you very much.
You're welcome.
All right, thank you. Somebody says, how strong is the therapeutic evidence for hydroxychloroquine, chloroquine, remdesivir, ivermectin, etc., and at what doses? So what I would say in relation to this is that for now, there is no drug that has shown been shown to be to be a cure for COVID for now. And chloroquine generally, chloroquine generally does affect it, and ivermectin also affects it in vitro. However, hydroxychloroquine and chloroquine have been found to show higher levels of mortality overall, and it is thought that it is due to the effect on the heart. In fact, the NHS essentially includes ECG, troponins, and cardiac biomarkers as part of the admitting panel for anybody with COVID. Why? Because some level of myocarditis is likely to have occurred ab initio at the time the patient is presenting. Now, if you already have myocarditis happening with some prolongation of QT ab initio, using hydroxychloroquine will likely cause more harm than good. And in a lot of the studies, they've had to be stopped short because of presumed increased mortality from hydroxychloroquine and chloroquine. As for remdesivir, I think the studies are still ongoing. And by and large, everything looks anecdotal, and it's not very sure whether people will have recovered. It's not very sure whether people will have recovered without treatment or not. Okay, I hope that answers your question, Doctor. Obviously, do you have anything to add to that?
No, I think that's splendid. That's just the way it is.
Okay, Somebody says he wants to know if air goes in through the surface of the mask, or if it is happening from the side of the mask that somebody is wearing. So it's difficult to tell, but essentially, one of the key reasons why N95 is proposed is not just, I'm having so much echoes here. One of the reasons why N95 is proposed is not just the surface, which filters 95% of things.
Chief, let me answer because of echo.
Okay, I'm meeting other people's own. Okay, so is that better now? I think that's better. So, but it's also because of the way it fits very snugly. So the truth is, a regular surgical face mask does allow some things to pass through. I think it gives about 75%, and N95 simply means that 95% of particles will be filtered out. Regular face mask does allow some things go through both from the front and from the side. That is why the correct way to wear it is to make sure that the malleable part is over your nose, and you pinch it to make sure that it covers your nose properly. Some people like to make it a little bit loose so that they can breathe better, but by doing that, you make it less effective in protecting. But over time, you get used to it. That's the truth of the matter. Okay, any other questions? All right, I think we'll stop here because of time. Like I said, we can always go back to the presentation at any time on the Zoom application. When you get to the Zoom application, what you will see there, you will see that you can request the webinar on demand and watch it again and again. For the next 8 hours also on Facebook, you should be on our Facebook page. You should be able to watch it there. I think you should follow us on Facebook and Instagram, cardiocare.center, where we'll also announce when the next lecture, but tentatively on Tuesday, we'll be going on the next round of lecture webinar series. Now, if you want to access your CMEs from this lecture, you have to send us a mail to Cardiocare, cardiocare@gmail.com or cardiocare@limithospital.org, and then we'll check our attendance records and issue you the CME accordingly. All right, thank you very much. In the absence of any question, I think we'll stop for now and call it a day. Thank you very much. God bless you all.
If never, no,